Today we are going to talk about the basics of pharmacology, especially in context of anesthesia. We will be focusing on two main ideas or principles. These are pharmacokinetics and pharmacodynamics. So when we give a drug to a patient, several things happen to the drug. These include how the drug is being absorbed from the site of administration, how it is distributed from the blood to the other parts of the body, how it is metabolized, and finally how it is eliminated. Together we call these processes pharmacokinetics. Understanding pharmacokinetics is important because it helps us know how long a drug will stay in our blood or for how long it will work. In simple terms, pharmacokinetics describes what our body does to the drug. As the drug moves through the body, it interacts with specific receptors located in various tissues and organs. When the drug binds to these receptors, it triggers its intended effects such as causing pain relief or sedation. This process is referred to as pharmacodynamics, which describes what the drug does to our body. Let's look into the pharmacokinetic principles first. Once again, pharmacokinetics is the study of drug movement in, through, and out of the body. It is the study of processes by which a drug is absorbed, distributed, metabolized, and eliminated by the body. These four processes explains how the drug levels in the blood change over time. Let's start with absorption. Absorption is the process by which a drug enters the bloodstream from the site of administration. The way a drug is administered impacts how well it is absorbed. For example, an intravenous injection goes straight into your blood while the oral medication has to dissolve in your stomach first. So let us look into some routes of drug administration and how it affects absorption. Oral drugs are by far the most prescribed method of drug administration. When a drug is taken orally, it enters the digestive system. In the stomach, the drug must dissolve in gastric fluids. This process is influenced by drug's formulation and stomach's pH level. Once dissolved, the drug moves into small intestine, which is the primary site of absorption due to its large surface area and rich blood supply. The drug then passes through the intestinal wall and into the blood vessels. From there, it travels through the hepatic portal vein directly to the liver. This phase is known as fast-pass metabolism. In the liver, a portion of drug is metabolized or broken down by liver enzymes, which can significantly reduce the amount of active drug. Once the drug leaves the liver, it enters the inferior vena cava, which carries it to the heart. The heart then pumps the drug into the systemic circulation, distributing it throughout the body. During this entire process, the proportion of administered drug that reaches the systemic circulation in an active form is reduced. The concept of bioavailability describes this reduction in the proportion of drug that reaches the systemic circulation. Most drugs outside anesthesia are taken orally, so the oral drugs like tablets or liquids have complex absorption behavior due to factors like stomach pH, presence of food, and fast-pass metabolism. However, in anesthesia practice, most drugs are administered intravenously. For IV drugs, absorption as traditionally defined does not apply because these drugs are administered directly into the bloodstream, bypassing barriers that influence drug absorption. Since IV administration results in an immediate entry of drug into the heart and then to the systemic circulation, this leads to 100% bioavailability, meaning the entire dose reaches the bloodstream. One of the main drugs used in anesthesia practice are local anesthetics. They are used for skin and tissue infiltration, peripheral nerve blocks, and in neuraxial anesthesia. When a local anesthetic is injected into the skin or tissues, it diffuses through the tissue until it reaches the nerve fibers where it blocks the nerve impulse generation. In contrast to oral drugs, absorption of local anesthetics from the site of administration is responsible for the offset of its action. Highly vascular areas such as muscle or mucosal tissues results in faster absorption compared to lesser vascular tissues like adipose tissues. The chemical properties of local anesthetics like lipid solubility, dissociation constant, and use of additives like epinephrine also influence the absorption of local anesthetics. We won't be discussing these properties here though. Likewise, in peripheral nerve blocks, local anesthetic is injected near the target nerve or nerves. Same factors determine the absorption of local anesthetics, which is responsible for the offset of its action. Similarly, epidural and spinal anesthesia results from the interaction of local anesthetics with the nerve structures, primarily of those located within the subarachnoid space. As the medication is absorbed into the bloodstream and cleared from the spinal fluid or epidural fat, sensory and motor functions return. Transdermal and transmucosal absorption also bypasses GI tract, allowing medication to enter the systemic circulation directly through the skin or mucous membranes. The skin by design presents a considerable barrier to absorption, and typically several hours are required for the clinical effect to commence following transdermal drug delivery. The drug must penetrate all the layers of skin to reach the capillaries where it is absorbed into the systemic circulation. The blood flow to the skin is also less compared to the muscles, resulting in prolonged absorption. And owing to its large surface area, the skin provides a depot of drugs, resulting in continuous drug delivery for a prolonged period of time. Several factors affect transdermal drug absorption. Smaller lipid-soluble molecules penetrate the skin more easily. Healthy, hydrated skin absorbs the drug better than dry or damaged skin, and of course, higher drug concentration improve absorption. Transmucosal absorption refers to the absorption of drug from the mucous membranes such as those in our mouth, like buccal and sublingual, nasal passages, rectum, and vaginal areas. Transmucosal delivery is characterized by a much more rapid absorption compared to transdermal delivery owing to a high mucosal blood flow. The drug diffuses through the mucosal epithelium, which is also thinner and more permeable than skin. Such drugs need to be non-ionized or lipophilic to efficiently pass through the mucosal membrane. I must say that subcutaneous and intramuscular routes follow the same principle of absorption as that of transdermal and transmucosal drug delivery respectively. Inhaled anesthetics are among the most commonly used anesthetic agents in clinical practice due to their rapid onset, ease of administration, and the ability to control the depth of anesthesia. They are absorbed through the lungs very rapidly. After administration, anesthetic diffuses from the alveoli into the pulmonary capillaries and then into the bloodstream. The driving force for this diffusion is the partial pressure gradient between the anesthetic in the alveoli and in the blood. The quantity of anesthetic taken up depends upon its solubility in blood and upon the pulmonary capillary blood flow. Once in the bloodstream, these agents are transported to the brain where they exert their anesthetic effects. The routes of drug absorption that we discussed earlier requires that the drug crosses biological membrane or cell membrane before it gets into the blood. This in short is called membrane transfer. Membrane transfer also applies to other pharmacokinetic principles of distribution, metabolism, and elimination, as all these processes rely on the drug being transferred between tissues or cells. There are several ways for a drug to move across the biological membranes. They are passive transport, carrier-mediated transport, and filtration. There are others too, but I think these three are the main ways. Passive transport is the transfer of drug across a membrane without the use of energy. It follows a concentration gradient, meaning that the drug moves from the area of higher concentration to the area of lower concentration. Simple diffusion is a form of passive transport where the lipid-soluble drugs can pass directly through the lipid bilayer of cell membrane. It works best for small non-polar or lipid-soluble drugs because they can easily pass through the fatty layers of the membrane. Carrier-mediated transport of drugs involves proteins in the membrane that help drug cross. There are two main types: facilitated diffusion and active transport. In facilitated diffusion, the drug binds to a carrier protein which helps it cross the membrane. Like passive diffusion, the process does not require energy and moves the drug from a high to low concentration. It is used by water-soluble polar drugs that are too large to pass directly through the lipid bilayer. In contrast to facilitated diffusion, active transport requires energy, usually from ATP, because the proteins move drug against the concentration gradient. This is how certain drugs, such as those that resemble essential nutrients like vitamins and amino acids, are absorbed into the cells. Lastly, filtration is the movement of drugs through small pores or spaces between the cells known as paracellular spaces. This typically happens in capillaries where a pressure gradient pushes small molecules through. Only small water-soluble drugs can pass through these pores as they are too tiny for larger molecules. The kidneys rely on filtration to remove drugs from the blood during excretion. We can appreciate membrane transport as we learn about drug solubility in blood or protein and in fat when we learn about distribution, metabolism, and elimination pathway of pharmacokinetic principle. For now, let's keep note of the properties of drugs like lipid solubility, water solubility, size of the drug molecule, and drug concentration gradient. In our next video, we'll discuss about distribution of drug from blood to the other parts of the body. Thank you. In the previous video, we have learned about the first principle of pharmacokinetics, that is, absorption of drug from the site of administration. In this video, let's see how the drug after being absorbed in the blood moves into different organs or tissues. When we talk about drug distribution, there are several stages involved. First of all, the drug needs to get absorbed into the bloodstream. The only time this doesn't apply is with intravenous administration, where the drug goes directly to the bloodstream. In the bloodstream or plasma, the drug can exist in two forms. It can either be free or bound to the plasma proteins like albumin. This binding is reversible, meaning that the drug can switch between being bound and unbound. Only the free form of the drug can cross cell membranes to reach tissues. The bound form, on the other hand, stays in the plasma. Now there is a balance between these two forms. So when the concentration of drug in the blood drops, some of the bound drugs get released. These helps maintain the active concentration of drug that can move into the tissues. Highly protein-bound drugs usually have a very slower onset and a longer duration of action. This is because the bound drugs acts like a reservoir, slowly releasing the free drug over time. Certain conditions like liver diseases or malnutrition can lower the protein levels in the body. When this happens, there is less protein available for drug to bind, which can increase the amount of free drug. This can lead to stronger effects of the drug or even toxicity. The initial distribution of drug is rapid and is greatly influenced by the blood flow to different organs. Free drugs quickly move to organs with high blood flow like the brain, heart, liver, and kidneys. These organs called vessel-rich groups receives a large share of cardiac output despite their small size. This quick distribution explains the rapid onset of anesthetic agents like propofol, which acts on receptors in the brain. It also explains the initial rapid decline of plasma drug concentration following an IV injection. After this initial rapid distribution, the drug then redistributes slowly to muscle and skin tissues. This happens because the plasma concentration of drug has equilibrated with the concentration of drug in vessel-rich groups. The free drug cannot move against the concentration gradient. Instead, the drug moves into muscles and skin which do not have any drug in it. Since muscle and skin have lower blood supply, the drug is delivered to these areas more gradually. Muscle tissue, particularly the fat within muscles, can act as a reservoir for lipophilic drugs, allowing them to accumulate and be released slowly back into the blood. Finally, the drug moves to fat and vessel-poor tissues like bones and cartilage, where distribution is much slower due to lower blood flow. Lipophilic drugs have high affinity for fat cells, serving as reservoirs for slow release later. That's all for now. In our next video, we will talk about volume of distribution. In the previous video, we have seen that the drugs from the plasma spreads to different tissue groups with varying blood flow and also capacity. These tissue groups represent an apparent volume where the drug must distribute until its concentration in the blood or plasma equilibrates with that of concentration in tissues. This volume is called volume of distribution or VD in short. It is basically a theoretical volume that describes how widely a drug is distributed throughout the body compared to its concentration in the blood or plasma. Mathematically, VD is expressed as the ratio of the amount of drug in the body to the concentration of drug in the plasma. To put it simply, the amount of drug in the body is usually the dose we give, and the plasma concentration of the drug can be measured from the blood samples. For example, let's say we administer 500 mg of drug and find that the plasma concentration is 10 mg per liter. Using this formula, we can calculate the volume of distribution as 50 liters. This means that the drug we gave distributes in a volume of 50 liters of body fluid. In reality, however, drug concentration in the sample we draw will vary over time because it takes time for the drug to distribute around the body. If we measure the drug concentration in a blood sample right after administration, it will be very different from the measurement taken hours later. This difference in timing will result in different VD values. To address this, we use different methods to determine VD based on the timing and sampling of plasma concentration. Let's go over these methods. The first one is the initial volume of distribution. This method is determined soon after the intravenous administration of drug. When a drug is administered intravenously, it rapidly distributes throughout the central compartment, primarily the blood and highly perfused organs. By taking early plasma concentration measurements, we can estimate the drug's initial dispersion. This process involves plotting the concentration of the drug at various times and then drawing an imaginary line back to where the concentration would be at time 0. This initial volume helps us understand the drug's immediate distribution before it starts to equilibrate with the peripheral tissue. Drugs that bind strongly to the proteins in the blood will have larger initial VD. Now, when we ignore the distribution of drug into peripheral tissues, the volume of distribution estimate will be inaccurate as peripheral tissues also take up drugs. An alternate method focuses on how a drug disperses after it has equilibrated between the blood and highly perfused organs and peripheral tissues. By that time, the plasma drug concentration declines in a more predictable manner as drug elimination begins. The VD is then estimated by extrapolating a line of best fit from the terminal elimination phase of the concentration time curve. If you don't understand what I said, think of the line of best fit as a straight line that represents the relationship between two sets of data. In our case, the plasma concentration during elimination phase and the concentration at time 0. It shows how the data points relate to each other in a scatter plot and can be used to make predictions. The initial volume of distribution and the extrapolated volume of distribution value both focus on the drug distributing into some compartments, whether central or peripheral. The next method, called area under the curve, is a non-compartmental way of estimating volume of distribution, which involves taking multiple blood samples over time to measure drug concentration. The area under the curve helps us understand the drug's distribution and elimination over time and includes the whole picture of how the drug distributes throughout the body. The last method is used to estimate volume of distribution for drugs that are given as infusion. It is called steady state method. For drugs that are administered as infusion, we measure the concentration once the drug reaches a steady state in the body, meaning that the rate of drug administration equals the rate of elimination. Of all the volume of distribution we discussed earlier, volume of distribution at steady state is probably the most useful one for calculating the loading dose. The loading dose, after all, is the dose we give in order to achieve a desired steady-state drug concentration in plasma. Alright, I went a lot in depth about different methods to calculate volume of distribution, but I think we are just okay knowing what they are without worrying about the line of best fit or area under the curve. These are for statisticians. Now that we are done with complex methods used to estimate volume of distribution, let's look into factors affecting it. The most obvious one is the measurement and the pharmacokinetic modeling used to predict volume of distribution. As we have seen, volume of distribution estimates are different based on the measurement time of plasma concentration. The properties of the drug affect how it distributes and hence the volume of distribution. These properties include size of the drug molecule, charge or ionization, dissociation constant, and lipid and water solubility. The size of the drug molecule affects its ability to passively diffuse out of the central compartment. Larger molecules will have difficulty diffusing, resulting in a smaller volume of distribution. The charge of a drug molecule significantly influences its distribution in the body. Highly ionized or strongly charged molecules are more water-soluble, meaning they are more likely to remain in the aqueous environment of body, such as plasma. They cannot cross cell membrane as they require carrier-mediated transportation. Moreover, these charged molecules can be trapped in bloodstream due to the interaction that occur between the charged molecules and proteins in the blood that have opposite charges. This binding limits the ability of the drug to passively diffuse out of the bloodstream and into the peripheral tissues. Also remember that only free drug crosses the membrane. The three next properties that determine the volume of distribution are interlinked. They are dissociation constant or pKa of a drug, their lipid and water solubility. The pKa of a drug determines its degree of ionization, which in turn influences its lipid solubility. The pKa of a drug is the pH at which the concentration of ionized and non-ionized forms are equal. Non-ionized drugs are lipid-soluble while ionized ones are water-soluble. Highly lipid-soluble drugs will have the highest VD values because they can easily cross lipid bilayer membranes by simple diffusion. Whereas highly water-soluble drugs will have difficulty penetrating lipid bilayers, leading to smaller volume of distribution as they are essentially limited to extracellular water. Distribution of drugs also depend on the properties of the fluid where it gets distributed. These properties are pH of the body fluid, total body water content, and the protein level of the body fluid. Let's look at the pH of the body fluid first. The interaction between pH and the drug's pKa determine the proportion of the drug that is non-ionized or lipid-soluble or whether it is ionized. When the pH of the environment matches the pKa of the drug is 50% ionized and 50% non-ionized. Now, most drugs are either weak acid or weak bases. For acidic drugs, the pKa is typically below 7. This means that in acidic environment, when the pH is less than 7, the drug will mostly exist in its non-ionized form, while in more basic or alkaline environment, the drug will become more ionized. In contrast, basic drugs typically have pKa value greater than 7. These drugs exist in their non-ionized form in basic environment and in ionized state in acidic environment. So, depending on the pH of the patient's body fluid, the ionization of the drug changes and so does its lipid solubility. Drugs are distributed throughout the body fluid, so a larger body water content typically results in larger volume of distribution for hydrophilic or water-soluble drugs. Several factors influence the body's water content, which can affect how drugs are distributed. In dehydrated patients, the lower water content causes drug levels to become more concentrated in the blood. As we age, body water content decreases, which reduces the volume of distribution for water-soluble drugs. Additionally, muscle mass decreases with age, leading to less tissue binding and further reducing the volume of distribution. For females, volume of distribution is generally lower than in males due to their lower body water content. On the other hand, when both body water and body fat content increases, as in pregnancy or obesity, the volume of distribution for most drugs also increases. These also include potential distribution into amniotic fluid and fetus in case of pregnancy. In cases like heart or renal failure, large fluid collection can sequester water-soluble drugs, effectively increasing their volume of distribution. As we have seen earlier in this video, most drugs bind to plasma proteins like albumin. So, when the protein levels are low, the increase in free drug can alter the apparent volume of distribution as the drug is more readily available to distribute into tissues. For example, in conditions such as liver diseases, nephrotic syndrome, or malnutrition, protein levels can be significantly reduced. All these conditions can lead to increased level of free drug which distribute readily to the peripheral tissue, thus increasing volume of distribution. Finally, in addition to these physiological factors, absorption into medical apparatus such as dialysis filters or ECMO circuit can also influence drug distribution. These devices tend to absorb drug in an unpredictable manner, leading to an apparent increase in the volume of distribution. This effect occurs because the drug binds to the surface within the apparatus, reducing the amount of drug available in the bloodstream and complicating the accurate dosing and drug monitoring. Now, let's talk about why the volume of distribution is important. First of all, volume of distribution helps us understand how a drug spreads throughout the body. If a drug has a high volume of distribution, it means that the drug spreads out into various tissues rather than staying in the bloodstream. These can lead to a lower concentration of drug in the blood, potentially requiring higher or more frequent dosing to maintain therapeutic levels. Conversely, if a drug has a lower volume of distribution, it means that the drug is largely confined to the plasma, resulting in a higher plasma concentration, which may require a reduced dose to avoid toxicity. In addition to this, drugs with higher volume of distribution distributes more extensively into tissues such as fat and muscles, leading to a prolonged duration of action because they are stored in these tissues and released slowly back into the bloodstream later on. These can increase the risk of toxicity if the drug accumulates too much in these tissues. Conversely again, drugs with lower volume of distribution remain largely in the blood, leading to quicker elimination and a shorter duration of action. In other words, volume of distribution helps us calculate the half-life of a drug. The formula for half-life of a drug is given here. Also, as we have seen, volume of distribution can change in special populations such as elderly, obese, and those with special medical conditions like liver or renal diseases. So it helps us make patient-specific dose adjustment. That's all for now. In our next video, we'll discuss about the compartment models of drug distribution. Earlier, we have seen that drugs are distributed into tissues and organs based on the amount of blood flow it receives. Accordingly, tissues were grouped into vessel-rich, muscle group, and vessel-poor group. Now, we'll look into the compartment model, which uses the same concept to divide the body into compartments or hypothetical spaces. The compartment model assumes that the drug distributes uniformly within each compartment. However, the compartments does not need to correspond to any specific anatomical space within our body. We have single compartment model where we assume our body as one big container where the drug distributes uniformly. Then there is two compartment model where the body is divided into central and peripheral compartments. Finally, the multi-compartment model assumes that there are more than two compartments, that is central, rapidly equilibrating and slowly equilibrating peripheral compartments. We will look into them one by one. The one compartment model is the simplest way to describe drug distribution and elimination in the body. This model assumes that all the tissues in the body are contained in a single compartment. This is just an approximation and doesn't account for delays caused by blood flow, protein binding, or tissue barriers we have discussed earlier. Once the drug enters the body, it is instantly and evenly distributed in this compartment, also called central compartment. This one and only compartment is the volume into which the drug distributes in one compartment model. Now let's draw an outline to understand one compartment model more clearly. The one compartment model or any other compartment model begins with drug administration. For anesthesia, it's usually a bolus administration or infusion. In one compartment model, the administered drug distributes instantly and uniformly throughout the body after administration. The body is treated as a single homogeneous compartment, meaning that the drug concentration is the same throughout all the tissues and fluids at any given time. The compartment, in other words, represents the volume of distribution. Finally, the drug leaves the body at a constant rate, typically through the process of metabolism or excretion. This elimination follows first-order kinetics, meaning the rate of elimination is proportional to the drug's concentration in the compartment. Now, what is this first-order kinetics? With first-order elimination or kinetics, a constant proportion or a fraction of drug is metabolized per unit time. The plasma drug concentration reduces by the same percentage from the total concentration at one particular time as elimination begins. Let's say there are 16 drug molecules before the start of drug elimination. Due to the constant rate of elimination, there will be 50% reduction in plasma concentration at regular intervals. If we look at the time for plasma concentration to reduce by half, which is the half-life of a drug, we can appreciate the exponential decay of plasma concentration. The first 50% reduction in drug concentration is the first half-life of the drug. So in this example, the drug molecule reduces by 16 to 8. As elimination continues, the remaining concentration is reduced by another 50%, resulting in 25% of original concentration. The remaining concentration is then again reduced by another 50%, resulting in only 12.5% of the original concentration, and it keeps going until it is fully eliminated. Please spend some time carefully studying this graph. But why does this first order elimination happen? The first order elimination occurs when the drug concentration is low and the metabolic enzymes or elimination pathways like liver and kidneys are not fully saturated. The rate of elimination is proportional to the drug concentration because the system can process more drugs as the concentration increases. For example, doubling the drug concentration doubles the elimination rate, or halving the concentration halves the elimination rate as given in the graph. In contrast to the first order kinetics, we also have zero order kinetics that occur when the drug concentration is so high that the elimination system becomes saturated. Enzymes, transporters, or other processes responsible for drug metabolism or excretion are working at their maximum capacity and cannot increase their rate, no matter how much drug is present. So, the system eliminates a fixed amount of drug per unit time, leading to a fixed amount of drug elimination rate rather than constant proportion. The elimination rate does not depend on the drug concentration, making the relationship between the dose and drug level non-linear. Drugs like phenytoin, alcohol, and high doses of aspirin follow zero-order kinetics at therapeutic or higher concentration. Alright, let's consider an example where a drug dose of 1 gram is injected into 1 liter of compartment. In one compartment model, the drug is assumed to distribute evenly and undergo first-order elimination. Graphically, we would get a concentration time graph like this one. The volume of distribution represents the size of the compartment into which the drug distributes. Since the compartment is 1 liter and the drug dose is directly injected into it, the initial concentration of the drug is simply the dose divided by the volume. So in this case, 1 gram per liter of drug is confined to this 1 single liter of body fluid. The elimination rate constant K quantifies the proportion of the drug eliminated per unit time. Suppose K is 0.5 per minute, meaning 50% of the drug is removed every minute. So at time 0, the concentration is 1 gram per liter. After 1 minute, it becomes 0.5 gram per liter. And after 2 minutes, only 0.25 gram per liter of the drug remains in the plasma. This exponential decline is characteristic of first-order elimination. There are whole drug classes for which pharmacokinetics are well predicted by a single compartment model. For example, highly hydrophilic drugs which are confined to body water usually have single compartment pharmacokinetics. Aminoglycosides are an excellent example of drugs that follow one compartment model. They have barely any tissue penetration and are essentially confined to the intravascular fluid volume or blood plasma. However, for drugs that are highly distributed throughout the body like anesthetics, a more complex model may be necessary. So let's dive into two-compartment model. Two-compartment models improve upon one-compartment models by incorporating drug distribution between two distinct areas, the central compartment and the peripheral compartment. This separation accounts for the distribution process that a one-compartment model cannot capture. After drug administration, the drug is assumed to be immediately taken up by the central compartment representing plasma and highly perfused tissues like kidneys, brain and liver. Later, the drug then distributes from the central compartment to peripheral compartment representing muscle, skin and fat. Now, let's draw two-compartment model. Just like one compartment model, the two-compartment model begins with administration of drug into the central compartment. After the drug administration, the drug concentration in the central compartment decreases rapidly as it distributes into the peripheral compartment. This is called distribution phase, which accounts for the initial rapid decline in serum drug concentration. It is denoted by K12. The same process causes the concentration of drug in the peripheral compartment to rise. The distribution phases occur until the drug concentration in the central and the peripheral compartment is equal. Once the equilibrium is established between the two compartments, the drug is eliminated primarily from the central compartment via metabolism or excretion. This phase is slower and also follows first-order kinetics. It is denoted by K10 in the diagram. During this time, as the drug is eliminated from the central compartment, the drug from the peripheral compartment moves back into the central compartment to maintain equilibrium. This redistribution is denoted by K21. So, in two-compartment model, the decline in plasma drug concentration occurs in two phases. The first is the distribution phase, characterized by an initial rapid decline in serum drug concentration with subsequent rise in drug concentration in the peripheral compartment. And the other phase is the elimination phase, marked by the slower decline sustained by the redistribution of the drug from the peripheral tissue stores. In other words, in two-compartment model, there are effectively two half-lives, distribution half-life and elimination half-life. Distribution half-life represents the time it takes for the drug concentration in the central compartment to decrease by half during the initial rapid distribution phase. Elimination half-life is the time taken for the total drug concentration in the body to decrease by half during the slower elimination phase after distribution equilibrium have been achieved. These two phases have clinical implications. For example, a highly lipophilic drug is easily distributed from the bloodstream and stored in the body fats. Such drugs initially exhibit a short half-life during distribution phase, but a much longer half-life during elimination phase due to the slow release from the fat stores in the peripheral compartment. The three-compartment model includes another peripheral compartment in addition to the two compartments we have discussed. The first peripheral compartment represents the highly perfused tissues like muscles, and the second peripheral compartment represents the scarcely perfused tissues like fat. These two compartments are also called rapidly equilibrating and slowly equilibrating compartments. The drug elimination, distribution and redistribution follows the same logic we discussed in one compartment and two compartment model. Like the single and two compartment model, the drug is assumed to be immediately spread into a central compartment. With distribution, the drug first distributes into the vessel-rich muscle compartment. The drug then spreads to the fat compartment until the plasma concentration of drug equilibrates with the fat compartment concentration. The changes in plasma drug concentration in three-compartment model can be explained in three phases. These are distribution, elimination, and terminal phase. Consider a highly fat-soluble drug. After administration, the drug begins to distribute rapidly throughout the body, including into the lean muscle and fat tissues. Hence, the plasma concentration of the drug reduces rapidly. At the same time, the distribution of drug leads to peaking of drug concentration in the two peripheral compartments. Lean muscle, which has a little fat, is not a significant storage reservoir for the drug. So, it reaches its peak concentration quickly. The fat compartment, however, absorbs a large amount of drug, acting as a significant storage site. Once the distribution phase concludes, the drug enters what is often referred to as elimination phase. During this phase, the drug is cleared from the blood and muscle compartment, but the fat tissue continues to store significant amount of the drug. The elimination phase transitions into terminal phase when the drug concentration in the fat compartment exceeds the concentration in the blood. At this point, the fat tissues begin to release drug back into the bloodstream. This redistribution of drug from the fat compartment slows the overall clearance of drugs from the central and the muscle compartment. Whole body physiologically based pharmacokinetic modeling is a detailed approach to pharmacokinetics that represents the body using multiple interconnected compartments that correspond to actual physiological structures such as organs and tissues. Physiologically based pharmacokinetic models use physiological parameters like blood flow rates, tissue volumes, and organ-specific enzyme activities often derived from anatomical and physiological data. Metabolism is an essential pharmacokinetic process that converts lipid-soluble or non-polar compounds into water-soluble or polar compounds. Polar molecules have partial positive and negative charges, which is similar to water. For example, salt or sodium chloride is a polar compound. So, when we put salt in water, the opposite charges of water and salt attract each other, dissolving the salt. Non-polar molecules like ethane, on the other hand, lack charges, so they can't interact or dissolve in water. This is important because only water-soluble polar substance can undergo excretion, whereas lipid-soluble non-polar substances are passively reabsorbed from renal or extrarenal excretory sites. Specifically, during metabolism, there is an enzymatic conversion of a drug from one chemical form to another in a process called biotransformation. Biotransformation has several possible outcomes. It can cause pharmacological inactivation, where an active drug is converted into inactive or less active metabolites. Biotransformation can also lead to bioactivation, where an active drug is converted into more active metabolites. Another outcome is pharmacological activation, where an inactive drug known as prodrug is converted into active metabolites, making the compound therapeutically more effective. Lastly, biotransformation can sometimes result in no changes in pharmacological activity, where an active drug is converted into metabolites that have equal pharmacological activity. The major site of drug metabolism is the liver. Secondary organs of biotransformation include the kidneys, lungs, intestines, skin, plasma, and nervous tissue or the brain. Two classes of enzymes are involved in biotransformation of drugs. These are microsomal and non-microsomal enzymes. Microsomal enzymes are primarily located in smooth endoplasmic reticulum, particularly in the liver. The most notable microsomal enzymes are the cytochrome P450 family of enzymes. Non-microsomal enzymes are found in various locations throughout the body, including the liver. These include cytosolic enzymes like alcohol dehydrogenase or glucuronyltransferase, mitochondrial enzymes like monoamine oxidase, and plasma esterases like acetylcholine esterase and pseudocholine esterases. There are two phases in biotransformation. These are phase 1 and phase 2 reactions. Phase 1 reactions, also called non-synthetic phase or functionalization reactions, exposes or introduce functional groups to increase the polarity of the drug molecules. The increased polarity makes the drug water-soluble for renal excretion. It also makes the drug chemically reactive to facilitate phase 2 reaction. The metabolites of phase 1 reaction can be activated, inactivated, or unchanged versions of the parent drug. These reactions include oxidation, hydrolysis, reduction, and many more. Phase 2 reactions, also called synthetic phase or conjugation reaction, conjugates or binds the drug or its phase 1 metabolites with the endogenous polar molecules like glucuronic acid, making it more water-soluble. These reactions include glucuronidation, sulfation, methylation, and others. The phase 2 reaction almost always results in deactivation of the drug. Although this is usually a sequential process, phase 1 metabolites may be excreted without undergoing phase 2 biotransformation, and phase 2 reaction can precede or occur without phase 1 reaction. Despite undergoing these two reactions, some drugs and its metabolites are not rendered water-soluble. In such cases, where the drugs are lipophilic, large, or conjugated, biliary excretion removes them in feces. Let's look into some of these reactions with examples. Oxidation reactions are the most common phase 1 reaction. They involve introduction of an oxygen atom into the drug molecule. These reactions are primarily catalyzed by cytochrome P450 enzymes. Midazolam undergoes oxidation to form 1-hydroxymidazolam, which retains pharmacological activity. Reduction reactions involve the gain of electrons or hydrogen atoms by drug molecule. These reactions convert functional groups into their reduced form. Halothane undergoes reductive dehalogenation, where halogen atoms are removed under hypoxic condition, forming trifluoroacetic acid and bromide ion. These reactive intermediates can contribute to hepatotoxicity. Hydrolysis reaction involves the cleavage of chemical bonds by addition of water. These reactions are catalyzed by esterases and amidases, breaking down esters or amide bonds in the drug. Remifentanil undergoes rapid hydrolysis to form remifentanil acid, which is inactive. Glucuronidation is one of the most common phase 2 reactions where glucuronic acid is added to the drug or its metabolite. This reaction is catalyzed by UDP glucuronyl transferase. Propofol undergoes glucuronidation to form propofol glucuronide, which is water-soluble and excreted in the urine. Glutathione conjugation involves the addition of glutathione to reactive intermediates of phase 1 metabolite. This reaction is catalyzed by glutathione S transferase. Halothane undergoes glutathione conjugation to detoxify its reactive intermediate formed during phase 1 metabolism. Halothane glutathione conjugates are water-soluble and hence excreted in bile or urine. Methylation involves the addition of a methyl group to the drug or its metabolites. Epinephrine undergoes methylation to form metanephrine, which is catalyzed by catechol or methyl transferase. Metanephrine is more water-soluble and excreted in urine. As the liver is the main organ involved in drug metabolism, let's look into the pharmacokinetic concept called hepatic clearance. Hepatic clearance is the volume of blood perfusing the liver from which a drug is completely removed per unit time. It is influenced by factors such as liver blood flow, enzyme activity, and drug binding to plasma protein as illustrated by this formula. Hepatic blood flow is the volume of blood flowing through the liver per unit time. Intrinsic clearance is the liver's inherent ability to metabolize a drug independent of the blood flow. It depends on enzyme activity of the liver. Fraction unbound is the proportion of drug that is free or not bound to plasma proteins. Only the unbound drug is available to pass through the liver cell and undergo metabolism. The concept of hepatic clearance can be better understood with extraction ratio. Extraction ratio is the fraction of drug that is removed from the blood during a single pass through the liver. To calculate extraction ratio, the concentration of a drug entering and exiting the liver should be measured. C-in represents the amount of drug delivered to the liver by hepatic artery before any metabolic activity has occurred. It gives an indication of the initial burden the liver must process. C-out measured in hepatic vein reflects the amount of drug that remains after the liver has metabolized or removed a portion of it. This provides a direct measure of liver's metabolic activity. By comparing the drug concentration in the hepatic artery and vein, one can calculate the hepatic extraction ratio. For example, if C-in is 100 mg per liter and C-out is 20 mg per liter, then the extraction ratio is 0.8. This means that 80% of the drug is extracted by the liver, leaving 20% in circulation. Using the extraction ratio, we can also calculate hepatic clearance. Assuming hepatic blood flow to be 1.5 liter per minute or 90 liter per hour, the hepatic clearance is 72 liter per hour. Based on the extraction ratio, the metabolism of drug can be grouped into flow-dependent or flow-independent metabolism. For drugs with high extraction ratio, the liver can efficiently metabolize the drug as it passes through it. This means that clearance is primarily determined by hepatic blood flow, as the liver's metabolic enzymes can process the drug faster than it is delivered. If blood flow to the liver decreases, such as in heart failure, the reduced delivery of drug to the liver lowers the clearance. This can lead to drug accumulating in the bloodstream and increasing the risk of toxicity. Propofol is an excellent example of the anesthetic drug with high extraction ratio. For drugs with low extraction ratio, the liver metabolizes the drug slowly. Clearance is primarily influenced by liver's enzyme activity and not by hepatic blood flow. Changes in enzyme activity such as induction, inhibition, or liver diseases can significantly impact how much of the drug is metabolized. The drug warfarin fall in this category. Drug elimination is the process by which a drug is removed from the body. These include two main mechanisms: metabolism and excretion. Metabolism typically occurs in liver, where the drug is chemically altered to form metabolites which can be more easily excreted. We have already discussed that in our previous video. Excretion is the irreversible removal of drug and its metabolites from the body, primarily through kidney or urine, but it can also occur through bile, sweat, saliva, and expired air. As a result of metabolism and excretion, the amount of drug in the plasma or blood is reduced. The volume of plasma cleared of a drug during its single passage through the organ of elimination is called clearance. This means that a fraction of drug is eliminated by the organ as the blood flows through it. Here is the formula for calculating the clearance. Now, let's say the concentration of drug in the blood prior to the passage through the organ is 10 microgram per ml. From this, the organ metabolizes or excretes the drug at the rate of 500 microgram per minute. We can then calculate the clearance as 50 milliliter per minute. This means that 50 ml of blood is cleared of drug per minute as the blood flows through the organ of elimination. So, clearance basically helps us understand how quickly a drug is removed from the bloodstream or plasma. These in turn help us calculate dosing regimes and half-lives. In other words, it describes the relationship between plasma drug concentration and drug elimination. Again, we have discussed concentration time graph in compartment model section of the video. Two processes contributes to drug clearance. These are systemic clearance, which we can call as out of tank, and intercompartmental clearance, which is between the tank. Intercompartmental clearance refers to the rate at which a drug moves between different compartments within the body. Compartments in pharmacokinetic refer to conceptual spaces where the drug can distribute, such as between the central compartment and peripheral compartments. This type of clearance deals with the distribution of drug between different organs. We have thoroughly discussed them in the compartment model video. Systemic clearance, also known as total body clearance, refers to the total volume of plasma from which the drug is completely removed per unit time, considering all the routes of elimination like renal, hepatic, pulmonary, etc. This type of clearance is concerned with the overall elimination of drug from the systemic circulation. The physiologic model of clearance explains drug elimination by considering the biological mechanisms and anatomical structures involved. Each organ, like liver, kidneys, and lungs, has a specific clearance capacity based on its blood flow, ability to extract the drug from the blood, and metabolic functions. Blood flow to an organ determines the rate at which the drug is delivered to the organ. Organs with high blood flow like liver and kidney plays a major role in drug clearance. Once the drug reaches the organ, it metabolizes or excretes the drug. This means that the concentration of drug in the blood leaving the organ of elimination is less than the blood entering them. The fraction of drug that is extracted by the organ during a single passage through the organ is called extraction ratio. Extraction ratio is calculated as ER is equal to C inflow minus C outflow divided by C inflow, where C inflow is the drug concentration entering the organ and C outflow is the concentration leaving the organ. Drugs with high extraction ratio are efficiently cleared and their elimination is often limited by the blood flow to the organ, known as flow-limited clearance. In contrast, Drugs with low extraction ratio are cleared less efficiently and their elimination depends more on the organ's capacity to metabolize or excrete the drug, termed capacity-limited clearance. Mathematically, clearance for an organ is represented as the product of blood flow to the organ and the extraction ratio. For instance, hepatic clearance is determined by the liver's blood flow and its extraction ratio. Same concept is applied to other organs like kidney. The total systemic clearance of the drug is the sum of the clearance by all the eliminating organs, providing a comprehensive measure of body's efficiency in removing the drug. The half-life of a drug is the time it takes for the plasma concentration of a drug to reduce to half its original value. The half-life is influenced by both the volume of distribution and the clearance of the drug, and it can be calculated using the following formula. I have discussed the volume of distribution in a separate video. When the volume of distribution is high, the drug is widely distributed in the body's tissue, leading to longer half-life. Conversely, when the volume of distribution is low, the drug remains mostly in plasma, resulting in a shorter half-life. A high clearance means the drug is eliminated more quickly, resulting in a shorter half-life. A low clearance means that the drug is eliminated slowly, leading to a longer half-life. The combined effects of volume of distribution and clearance determine the overall half-life of the drug. A high volume of distribution and a low clearance results in a long half-life, while a low volume of distribution and high clearance results in a shorter half-life. When both volume of distribution and clearance are high or both are low, the half-life is intermediate depending on their relative magnitudes. In practical terms, drugs with long half-life require less frequent dosing to maintain the therapeutic level, while drugs with short half-life needs more frequent dosing. In pharmacokinetics, the concept of half-life can vary based on different contexts. Elimination half-life is the time it takes for the plasma drug concentration to reduce by half due to elimination process such as metabolism and excretion. It is calculated using the formula we have seen earlier. The elimination of a drug can follow either first order or zero order kinetic. In first order kinetics, the rate of drug elimination is directly proportional to the drug concentration. This means that the constant percentage of drug is eliminated per unit time, regardless of plasma concentration. In zero order kinetics, the rate of drug elimination is constant and independent of drug concentration. This usually occurs when the elimination mechanisms such as metabolic enzymes or transporters are saturated. Distribution half-life refers to the time it takes for a drug to distribute from the central compartment or plasma to peripheral compartment. This is particularly relevant for drug that exhibits a multi-compartment model of pharmacokinetics, where there is an initial rapid decline in plasma concentration due to distribution, followed by a slower phase due to elimination. The graph given here was discussed in compartment model video. Context-sensitive half-life is particularly important for intravenous infusion of drugs. The context-sensitive half-life refers to the time required for the concentration of drug in plasma to decrease by 50% after discontinuation of continuous intravenous infusion. The term context-sensitive indicates that the half-life is influenced by the duration of drug infusion or the context in which the drug was administered. After an infusion is stopped, the drug redistributes from the peripheral compartments or tissues back into the central compartment or plasma, which can prolong the time it takes for the plasma concentration to decrease. Unlike the standard elimination half-life, the context-sensitive half-life varies with duration of infusion. For many drugs, longer infusion relates to longer context-sensitive half-life. For example, Fentanyl has a contact-sensitive half-life that varies with the duration of infusion. For short infusion, the contact-sensitive half-life is relatively short, allowing for a quick recovery as the drug is rapidly redistributed and cleared from the body. However, with prolonged infusion, the contact-sensitive half-life increases significantly. This is because fentanyl, being highly lipophilic, accumulates in fat tissues and then slowly reaches back into the bloodstream, prolonging its presence in plasma and thus extending the recovery time. Unlike fentanyl, propofol has a relatively short contact-sensitive half-life even after prolonged infusion. Propofol's pharmacokinetic profile involves rapid redistribution and metabolism, ensuring that its plasma concentration decreases quickly after the infusion is stopped, regardless of the duration of administration. The two formulas given here are used to calculate loading dose and maintenance dose. The formula was discussed in the volume of distribution video. The loading dose is designed to quickly achieve the target therapeutic concentration of drug in plasma by accounting for drug distribution. The volume of distribution is used here because it describes the extent to which a drug distributes throughout the body's compartment. When calculating the loading dose, the goal is to ensure that the initial dose fills the entire volume of distribution to reach the desired concentration. The maintenance dose is intended to keep the drug concentration within the therapeutic range over time, compensating for drug that is continuously eliminated from the body. Clearance is the appropriate parameter here because it quantifies the body's ability to remove drug. To maintain a steady state concentration, the rate of drug administration must equal the rate of drug elimination. The rate of drug administration here is the maintenance dose.